Okay, welcome to those that are joining us for this week's YP Speaks with the Young Professionals Chronic Disease Network. We have a really exciting discussion for you to join in on today. We actually have two guests joining us. So Jonathan J. and Chelsey Canavan from Management Sciences for Health. So this is a global nonprofit that develops sustainable health systems in Africa, Asia, Latin America, and the Middle East. So John is an attorney, bioethicist, a senior writer for Management Sciences for Health. He was previously affiliated with Georgetown University and the National Institutes of Health. Jay serves as a coordinator for Health of All post-2015, Health for All, pardon me. So it's a global campaign that of civil society organizations advocating for universal health coverage in the post-2015 development agenda, so after MDGs. Chelsey is also a research and communication specialist with MSH. She also serves as a deputy coordinator of Health for All post-2015, so that's their connection there. So again, the global campaign of civil society organizations. She won the ASPPH Allen Rosenfield Global Health Fellow at the U.S. Centers for Disease Control, congratulations there, and has an MSPH in Health Policy Management from the University of North Carolina. So we do have a few participants that look to be joining us. So Brian, we also have enabled our Q&A box on our Google Plus events page. So for those that are joining us and viewing the live broadcast, feel free to chime in at any time. We'll just work through a relaxed manner here and moderate questions as you have them. So I will pass this over to Chelsey and John.
Thanks, Desiree. So sorry, I see one person's face down here, and did you say that's Brian?
Yes.
Would it be okay
Yes.
to just chime in and to talk for a second about what he does, and so we can tailor the conversation a little more?
Yeah, of course.
Sure. I am a practicing pharmacist and I guess also attending GW for public health and global health, design monitoring and evaluation. So I am fairly new to the global health arena, but I am passionate about chronic diseases. Primarily, I was born in Kenya. It's something that a lot of my family members have suffered from, and so it's kind of one of those, I guess, pharmacy is a background that sort of complements addressing chronic diseases, and it'd be neat to do it in a global setting. So,
absolutely. Yeah. So we'll see if we can bring out the medicines piece as much as possible. All right. So we. All right. Okay. We're going to screen share, right? And so we.
So we should be working through the entire screen share.
Right. We are. We're just the screen is just frozen temporarily. Can you still hear us right now?
Yeah, your audio is working perfectly.
Okay. Hopefully it'll just take a second for PowerPoint to respond. Oh, try stopping the screen share.
Lag times are bound to happen, so no worries on this end.
Okay. This will. Hopefully only take another second. We're restarting PowerPoint just to keep you updated.
No concern. And it looks like we have another guest. Caitlin, thank you for joining us. Oh.
All right, can you see the slides now?
Yep.
Great. So we'll be talking today about why the chronic disease response needs universal health coverage. And we're going to talk for hopefully maybe just over 10 minutes, leaving plenty of time for to really get in there with Brian and see what kind of questions you've got and what you're most interested in and what we can talk more about and get your take on the project that we're just starting. The background on this is that we've been working on UHC at MSH both from an advocacy standpoint. So we have this civil society campaign arguing for UHC, especially in the post-2015 UN framework. And we've also been running campaigns in 3 countries, Ethiopia, Kenya, and Nigeria, advocating for UHC reforms in those countries. So we've been doing a lot of advocacy on UHC and are at the same time trying to connect UHC to different health areas and different priorities in global health. And so we'll be talking a little bit about that as we go along, and that's where this project comes from. So we've written some blogs on this topic, and the next step is that we'll be working with a group to write an article for journals. So the first question here might be why everyone it's at least it seems to us, talking about UHC in global health. And in a way, it's been kind of slowly developing, where the right to health, the idea that everyone has access to a progressively realized access to health services, starts in the late 1940s. The idea of everyone needing, deserving access, and governments having an obligation to provide access to basic health services ramped up in the late 1970s with the Alma Ata Declaration, but then lost steam for some political reasons we can talk more about. But then this picked up again where during the Millennium Development Goal era, so starting in 2000 with an end date of 2015, the UN has been really focusing on 3 health areas, HIV, TB, and malaria, maternal health, including reproductive health, and child health. And these have, as you both know, have been guiding global health for a long time. And it's partly in response to what's considered an overly disease-focused, siloed approach to global health that many people are now calling for countries to go back to this idea of basic services for everyone, particularly in a way that's affordable, so that people aren't facing high out-of-pocket costs when they get sick, which is throwing people into poverty, reinforcing patterns of impoverishment. So that movement has ramped up just as the framework that will replace the Millennium Development Goals is being negotiated. That will go into effect in 2015, and the leading proposal right now, which is going to be the basis of the final round of UN negotiations, is to have a target under the overarching health target, which would call for the text that we've got there at the bottom, which is achieving UHC, including financial risk protection. So that's that affordability piece. And then, but looking at affordability as one piece, another being access to quality services as another. And then for some, what I would say are more political reasons, language there on access to medicines and vaccines. And certainly that's from the pharmaceuticals side, that's really important. That was going to come into the framework somewhere, and just for political reasons ended up coming in under UHC. And it's much less clear what that component of the goal means as opposed to the UHC piece. So there have been many attempts to define UHC. The most basic, most broadly used one is the one in the box on the left, which is the idea that it's policies whose goals are ensuring that all people obtain the health services they need without suffering financial hardship. So that's often described in terms of three major dimensions. The first is how many people are provided for. The second being how many services they've got access to. And third being how much they have to pay when they need those services. On the right is the language from the 2012 UN resolution supporting UHC, and that reflects what I would call the broader political agenda behind UHC, or as applied to UHC, which is to say, to point out also that in addition to focusing on those three major dimensions, it's also important to address discrimination, to circumscribe in some ways what's expected in terms of services. So that would be a limited package of services that's limited, but on the other hand is expansive enough as to include health promotion and prevention and rehabilitation, so that it's not just about treatment. And then those other pieces that you see there. And then finally, a special emphasis on the poor and vulnerable and marginalized populations, so that it is widely understood that the right pathway towards universal coverage shouldn't be just the lowest hanging fruit, who often will be the middle class working in the formal sector. Instead, and because those are the people who are living in cities who are the easiest to bring services to, the biggest impact and the most equitable way to do it is to start with the people who currently have no access to affordable services, which in many countries is many people. So this slide frames the approach that we're bringing to this issue, at least at this stage in our research. I know it looks complex, but the basic idea is UHC is an objective, and it'll take a lot of policies, a lot of different kinds of policies to achieve that objective. So many people understand UHC is really focused on health financing reforms, and so that reforms that look like insurance, that provide risk pooling and prepayment. So you're bringing more people together in a big to be covered under a fund, and the more of the money going to pay for their services is paid upfront, both through national budgets, public budgets, and in some cases through individual contributions, which would be made on, let's say, an annual basis rather than only by the sick when they get sick. So that's just basic insurance principles. There's also the idea that most developing countries will need to increase the amount of money that they devote from national budgets to health. And then finally, once you've got these bigger, improved financing mechanisms, you can use those to enact these purchasing reforms. So now that you've got this money and you've got a big purchaser, that purchaser can decide what it's going to pay for, and it defines that set of benefits that we talked about in the last slide. And so that's one area where, for addressing chronic disease in countries that currently have very little very few public programs for chronic disease, that's a really obvious place to start in terms of delivering individual health services for NCDs and starting to address the equity gap, Chelsey will talk about. The next area is service delivery reforms. And so, as you can see, the arrow behind this, behind the table here, is going from very darker yellow, those financing reforms that are really closely associated with UHC in the public consciousness, to ones that are progressively less closely associated. But even service delivery reforms are considered as a core element of UHC reforms, particularly the idea that you integrate platforms. So among the many platforms that are out there now under the MDG approach, the criticism is too many of them are focused on, let's say, HIV services, maternal health services, and not providing services in an integrated way. And then other reforms that would decentralize service delivery to the community level. The others, and then Chelsey will start addressing these. As we look ahead, there are other health systems building blocks. The human resources for health and the medicines communities have been talking about UHC and the kinds of challenges that you face. Governance and health information, less so, but these have clear implications for the chronic disease agenda. Similarly, when you talk about a basic everyone getting a basic package of benefits, it's not clear that that includes all the kinds of health outreach and community engagement that would be necessary to really address NCD risk factors, and Chelsey will touch on that. And the final category, which is bridging beyond the health sector, and that's UHC is generally pretty narrowly defined in terms of health sector interventions, but for chronic diseases and many other conditions, the health sector needs to work effectively with other sectors, and so we're trying to bring that into the UHC agenda as well.
Part of the focus of UHC that John was just talking about, this focus on poor, vulnerable populations, inequities within countries, but also between countries. And as one example, your chance of surviving breast cancer. In a high-income country, it's about 80%, and in a developing country, it's less than 40%. And these inequities become really stark when you start looking at these types of NCD health outcomes. This is a table showing the incidence and mortality rate for cancer for men and women in developed and developing countries. And there's a lot of numbers here, but if you just look at the bottom, you can see that although the incidence is much lower in developed countries, mortality rates are about the same. And looking up above, just one example of cervical cancer where both incidence and mortality are much higher in developing countries. This gap in health outcomes is across all areas. This is an example of deaths due to diabetes in people under 60. The largest percentages are in Africa and parts of Asia, even though we know that the incidence is much lower in most of these countries. And you look at cases of undiagnosed diabetes. It's also higher in those countries. So you have a situation where this gap in health outcomes, you can see, is highly attributable to a huge gap in health services provided in a lot of these areas. So one of the things that UHC does that is on the left side of John's last slide was mobilizing resources for health and bringing more domestic funds for health. This is just showing diabetes-related health expenditures per diabetes patient. And these expenditures are lowest in the countries that have the highest undiagnosed cases and the highest mortality. And that's not really a surprise, despite this kind of large and growing challenge of non-communicable diseases. Very minimal resources are allocated to this area. National governments certainly aren't really stepping up in this area, and the donor community is not either. Only about 1% of all development assistance for health goes to non-communicable diseases. So if your national governments and donors aren't paying for this, that means that most of the cost of NCD care treatment currently comes from out-of-pocket payments, making NCDs a really prime cause of catastrophic health expenditures and really exacerbating these social and health inequities that we're seeing. So when a country, so a country that has increased resources for health and has developed some type of financial protection mechanism, which is insurance, they have to figure out what to pay for with this new pool of funding. So they typically develop or define a package of health services that is going to be covered by an insurance scheme or some type of financial protection mechanism. And to do this, they really look at the primary causes of illness in the population and the effectiveness and affordability of interventions. And this is where we really expect to see a bigger expansion of NCD services as people are considering the highest impact interventions that their funding can buy. It's impossible to ignore the benefit of providing NCD services. A good starting place for countries doing this might be the WHO best buys. If you're not familiar with them, they're a set of low-cost, high-impact interventions such as cervical cancer screening or counseling and drug therapy for heart disease. They cost between just $1 and $3 per person to implement and are partly self-financed by things like tobacco taxation. And this is just a minimal set that can be built out over time as countries experience economic growth and are able to mobilize additional resources for health. This is exactly what's happening in the Philippines, and the burden of NCDs is high. NCDs cause about 30% of premature deaths. The Philippines has a universal health coverage scheme called PhilHealth that covers most of its population, and now they have introduced into PhilHealth a package of essential NCD interventions. This is a set of low-cost early screening and treatment services that are now covered by this social protection scheme. And these include assessments for risk factors like tobacco and overweight, referrals for heart disease and high blood pressure, and also the inclusion of essential drugs for hypertension and diabetes. So also within this essential benefits package is where you start to see that essential medicines piece coming into play, because you get these prescription drug benefits often covered under an insurance program as well. So in order to, once you have financing in place and you've developed this package of services that is supposed to cover your population, you also need to ensure that these services are accessible. So UHC can really play a role in catalyzing really needed investment in the health system, like in medicines or in human resources for health. Because NCDs often require long-term care and really can't be treated in isolation, there's a good opportunity to integrate NCDs into existing platforms, and this is happening with HIV, where the international community has historically put a lot of effort and a lot of funding, and there are some really strong platforms for HIV, which is also chronic in nature, to integrate NCDs into those models that already exist. And UHC can also strengthen primary care and community models of care that can detect and respond to NCDs more effectively. This is what's happening in Rwanda. Rwanda is a great example of a country that has a near universal health coverage program, and they're incorporating NCDs into that. In the early 2000s, HIV was decentralized in Rwanda, first to the health districts and then to the health centers and down to the community level, in order to provide that chronicity of care to HIV patients in the country. Starting in 2010, Rwanda has started building NCDs into that model, decentralizing down to health centers and down to the community level. And this is showing that model that they use in Rwanda, but it's also a great example of how integrating chronic care into that type of platform can be a really beneficial thing to do, especially in a low-resource country like Rwanda and probably Kenya and other places with similar settings. So this is going back to kind of all the way to the right side of John's last slide, and and I won't go through it in too much detail, but about the potential reach of UHC. And this question becomes really apparent when you start thinking about prevention of NCDs under a UHC program. The delivery of services for screening and early treatment within the health sector are kind of all the way to the left on that model, and then as you move over, these public health approaches like surveillance and risk communication that can be really effective in responding to things like Ebola or polio are should be included in order for UHC to really achieve its goals. With NCDs, we see that some of the most effective prevention addressing risk factors comes from multi-sectoral approaches or approaches outside the health sector. And these might include tobacco, taxation, health education, or urban planning. So, you know, and I guess we would love to hear from you too, in addition to any other questions you might have on how you see that fitting into a UHC theme or program. I think that's it. We can open it up for questions.
Yeah, I mean, just to sum up quickly, I think our general approach is saying, even within the very well-established UHC, people's understanding of UHC, there's a lot of promise for NCDs. There's a lot of promise for chronic disease, but a more expansive vision of UHC and the UHC agenda will have even more promise for chronic disease.
That was really great, guys. Thank you so much for providing such a thorough overview and even exemplifying some of the issues on the ground or even areas that have had successes. I know you spoke to the role that advocacy has played initially. Can you touch on some challenges that you have already stumbled across or do foresee in the acquisition of funding or moving through, I guess, your arrow model from the left to right? Yeah, I'll just start with that point. Brian, you can feel free to chime in. Again, we have a few viewers as well from our Google Events page. Please feel free to chime into the question and answer box, and we'll be sure to include those in our discussion.
Thanks, Desiree.
Right, so I mean, one of the challenges is just that when you think of UHC really expansively, it implicates partnerships with so many other areas. And thinking about, I mean, if you're really looking to, let's say, think about what would be the most efficient supply chain for medicines, particularly with an eye towards building in distribution of chronic disease essential medicines, then the people who are working on HIV supply chain and other areas need to be at the table and need to be encouraging of a more integrative approach. And it's not clear that kind of leadership will come from the top of those silos, right? It would be the people at the country level realizing that if we're going to achieve these objectives, and which will include specific post-2015 targets for UHC, it's going to be them seeing that the only way to do this is in a really integrative way and with a lot of different kinds of partnerships. And so I think this points towards a new era of global health that advances the country ownership agenda and will really bring in a lot of, will be more bottom-up.
And actually, Kenya is kind of a really good example of this, because in UHC conversations with the country, there is a national hospital insurance fund that already exists and covers a lot of the formal sector. And so there was a lot of civil society talk and pushing on the government, which had committed to UHC, and it turned out that the NHIF was a really important partner to bring to the table and said, hey, we need to do these conversations too. And Brian might know more about that than I do, but it's a good example.
Medicine. Go ahead.
Oh, I was just going to say, I was going to echo what Desiree had said about great coverage on the topic. Very thorough. And you guys raised a lot of interesting points that I guess I hadn't really thought about with the topic. John, you had the roadmap slide up there, and which was a great layout, sort of kind of the progression of things. Potentially and hopefully, and I was interested in who you guys or what institution you guys thought would handle the pool of money that would kind of go into the domestic funds and risk pooling.
Can I also pair with that what you think? So funds, and then speaking to the integration of partnerships, whether frameworks. I know that partnership frameworks and the maintaining accountability and all of that transition, especially when you're bridging silos. I guess just speaking to that.
Right. So in general, what you're talking about for UHC on that financing side are national pools that are as big as possible and generally publicly managed. I mean, there are the literature on UHC is not supportive of private insurance as a major mechanism of prepaid funding. So, if you're thinking about sort of different potential sources in country, there's a real focus on public funds. In thinking about the sort of global health architecture piece, many countries have big programs that are primarily funded by international partners, and I think the long-term idea is that those funds would come through the national pool, because that same purchaser can purchase as effectively, it should be able to purchase as effectively and more efficiently individual health services for something like HIV or antenatal care or anything like that. So that's the idea of sort of long-term integration of funds. In the short term, it's fine to say HIV services aren't covered by this insurance scheme, but they're provided for free by our global fund supported program. That's really short. So that's sort of a short-term versus long-term idea. But partnership frameworks, for sure. I mean, for something like UHC, we've seen how important they are in specific health areas, but on something like UHC, there's that much more coordination needed, particularly because there's money coming from all kinds of sources, all kinds of partners. And so I've been pushing for something like a UN-hosted partnership like UNAIDS or PMNCH that would be a platform for bringing together multiple stakeholders on UHC.
And there's also, I think definitely a role for the private sector, and every country is so different in their health system. There's a lot of health services are delivered by the private sector, so there's definitely a really strong need to pull all of those parties into partnership frameworks. And then just your last point on accountability, I think this is where we see a really huge role for civil society. And there are a lot of countries and governments, because it sounds really good to say that we're going to provide health services to everyone. And civil society plays a big role in holding governments accountable to make the reforms that will make that happen. So that's part of what we've worked on here in the Health for All campaign that is operating in 3 countries in Africa to mobilize civil society to hold people accountable.
Thank you for that. We'll have one last call out for questions for our viewers. Otherwise, Chelsey and John, you can feel free to have some final words, some closing notes with us. As we move forward. So I'll just give a few minutes for our viewers to pipe up with any questions should they have them.
Great. I mean, we really encourage, if anyone sort of comes up with questions or thoughts that they'd like to send us offline. We're really eager to hear from the chronic disease community, particularly young professionals. I mean, I think part of what I think we both see chronic diseases as the global health, public health challenge of our professional generation. And so thinking about how UHC in particular can drive a response that's fit for that challenge is important, because the UHC was, UHC has come in as an effort to break down the silos that the MDGs have proposed, but if UHC is unduly siloed in looking at just health financing or just the health, or even just the health sector, I mean, it really won't be the right kind of tool, a fully adequate tool for this huge problem of chronic diseases. So that's, I mean, that's the perspective we're bringing to this problem, and I think it's really up to us as young professionals to be looking ahead to, you know, what will people think about this post-2015 framework in 2025? You know, will we be looking back and saying we should have known that we weren't creating the kind of approaches that would solve this problem, or will we say, you know, we really did do this in a forward-looking way?
So I do have one last question that was just added. So I guess this will be the final one we'll take as we wrap up today. So it's speaking in terms of long-term approach and in-country funding sources. So that's the framework. So they're just asking, we have Noella asking if you could talk about some of the mechanisms, for instance, examples or best practices that might be used to provide coverage for the lowest wealth percentile in accessing CVD care or chronic disease care. I know that you did have a graph to speak to that, so maybe you could just highlight a few of the integrated services that you mentioned, or however you see fit.
You want to talk about sort of benefits packages and?
Yeah, so I guess the question was about financing and then also the benefits going into it. So in terms of the financing piece, I think it's going back to that pooled mechanism where people often will pay in, they'll prepay, which is what a typical insurance will look like, and then everybody is covered for a certain amount of services. And this is done in really different ways. The way that Rwanda had done it was through a series of kind of community-based health insurance schemes where the community kind of looked out for itself, and everybody would pay in a very small amount into a pool of funding that would then cover health services for the community. That's putting it in a very basic way. In the formal sector, it's much easier because you get contributions from people from the money they're earning, and also from employers who can pay into a pool.
In Rwanda and elsewhere, though, the financing piece has really focused on, in order to get the package that Chelsey is talking about to the poorest who really need it, identifying and finding ways to enroll people who can't afford anything, where basically any premium is going to rule them out. So that's where the tax-based approach is, that where effectively you have rich subsidizing poor and devoting resources to coverage for people who can't afford it.
So once you have that in place, I think it's a matter of looking at what are the health issues in your population, what are the greatest causes of illness and disease, and developing a set of things that will be covered for everyone in the population who's part of that program, and ideally that is everyone in the population. And I think that's where kind of the WHO Best Buys, and I'd encourage you to Google it and look through it if you're interested, but that is a really good starting place of low cost, really cost-effective, I should say, measures that are kind of individual health services that can be covered under some type of financing mechanism. And
to push beyond those services, beyond those Best Buys, to a more comprehensive set of services, then that's where continued focused advocacy from civil society and many others will be necessary, even within the context of UHC. I mean, there needs to be accountability for making the right decisions about resource allocation.
Yeah, and I'll just add to that, I mean, this is making the assumption that you have some idea of what the needs are in your population. So even pushing for, data on the greatest need and how to allocate, to help inform decisions on how to allocate resources is really important.
That's awesome. Thank you guys so much for breaking that down for us. And thank you for those that will be joining us both now and later on. We look forward to your I guess, feedback, hopefully. If you do have something you want to follow up with Chelsey or John, just email YP-Chronic and we can happily connect you. So with that said, I'll just wrap up today's session. Thank you both for joining us. It was an awesome presentation, great discussion, and hopefully we can have follow-up. So ypchronic@gmail.com if you have further questions, and we'll look forward to seeing everyone as well in the new year as we launch our 2015 YP Speaks.
Great, thanks so much.
Perfect. Have a great day, everyone.